Okay, so we're going to talk about the intra-aortic balloon pump. It's also abbreviated IABP. And essentially, it's a balloon that's inserted through the groin in cath lab or cardiac surgery, but we don't do cardiac surgery here. It goes in through their groin, and this balloon sits in their descending aorta, which is right there, and it sits just above their renal arteries. And it inflates during diastole. And when it inflates, blood is displaced, so that way it's easier for the left ventricle during systole to perfuse more blood to the coronary arteries and to the rest of the body. During systole, the balloon deflates, so blood can go down the descending aorta to the rest of the body. But also when it inflates, blood is pushed up to the coronary arteries as well. So the indications for it is like any acute coronary syndrome or any ischemic event, cardiac surgery, or like heart failure or left ventricular failure. That's what we would see it for the most, probably here. But it decreases the workload on the heart and decreases the oxygen demand for the heart as well. So it essentially just increases perfusion. So there's a trigger event. The balloon just doesn't go like this 24/7. It gets triggered by something, and we always use the ECG. So it gets triggered by the R wave, and that's what signifies, okay, I'm gonna need to pump here in a little bit, the balloon does. And so it looks at our arterial line waveform as well. And at this dicrotic notch on our arterial line waveform, that's when the balloon starts to inflate because the aortic valve is closed. And so it inflates, and then blood fills up here, and then it deflates, and blood gets pushed out. So we're gonna talk about, there's 3 different frequencies of how often this balloon inflates. There's 1-to-1, 1-to-2, and 1-to-3. So 1-to-1, every R wave that triggers it is gonna get an inflation and deflation. 1-to-2, it's every other. 1-to-3, it's every third heartbeat, essentially. And so there's some things we have to document. Like every hour, we need to be documenting our pulses and our sites because, of course, the balloon shifts, something like that. It can occlude blood flow, or if there's a clot or something like that. So we check all our pulses every hour. There's also a few pressures we need to chart every hour as well. So one of those is going to be the augmentation. And you see these peaks right there? The tall ones? That's when the balloon is inflated. These little peaks just before that, that's the patient's systole. That's them, their heart contracting. That's the left ventricle contracting. The reason that this top one is much higher is because when there's more blood inside, here when it's inflated, there's an increase in pressure. So this is called the augmentation. It's always going to be higher than the patient's true systole because there's an increase in pressure, increase in blood. So we can kind of move over here now, and I'll show you the rhythms. So the screen's always going to be locked when you're not using it. It's in standby right now. So all you have to do is hit unlock to unlock it. So we'll start here. It's always going to be in automatic mode. If it's in semi-auto, you can adjust other things, but for our purposes, it's always going to be automatic, unless there's a physician making changes or really specific details are happening. So the trigger, that's what we talked about. It's the ECG. You're most likely never going to change it. You can do pressure, which would be your arterial line, but 90% of the time we're going to do ECG, and that's the R wave there. Sources, this is just telling us where's it getting its information from. It's just going to be whatever's plugged into the machine, so you never have to change your source. This is what you will have to change, is the frequency. So you can do 1-to-1, 1-to-2, or 1-to-3. So I can start it there. And you can see right now we're in 1-to-1. You have your patient's blood pressure, and there's that augmentation I was telling you about. So that's higher, so that's good. If we changed to 1-to-2, you can see the waveform's going to change. And now every other beat is going to get an inflation and deflation, and it slows down too. And then even with 1-to-3. And then 1-to-3 and 1-to-2, those can be like weaning modes, trying to get a patient off of this. Mostly when we get a patient from cath lab, they're going to be in 1-to-1 because they need the most help. But the 1-to-3 will be like we're trying to get them off, and we're seeing how well they do. And so you notice when we do anything but 1-to-1, so 1-to-1, there's a blood pressure, but if you go to 1-to-2, now we have some extra numbers. So in 1-to-1, these are called your assisted pressures, assisted systole and diastole. Those pressures are because everything's being assisted right now. If you go 1-to-2, every other heartbeat is being assisted, so you have some of the patient's true blood pressure that's going to be unassisted. So the ones that aren't labeled are the assisted, and then you have your unassisted labels as well. So the unassisted is 102/53. That's the patient's like blood pressure without any help. Then you have your map, you have your augmentation. You always want to make sure your augmentation is, you have to set an alarm for it. So alarm is full on max. And then our alarm, I'll turn it on here. It's always going to be 10 less than what your true augmentation is. Because if your augmentation drops, that means that for some reason pressure isn't building up when it's inflated, which means there's not blood that's not building up, so there's a problem. Your balloon might have a leak, it could be in the wrong place, or something that could be too far up, or something like that, which is a problem where you'd have to page the doctor. So every 2 hours, this patient is a 1-to-1, by the way, so it's the nurse's only patient, so there's a lot you have to deal with. But so every 2 hours, you're gonna have to chart all these unassisted and assisted pressures. You try your augmentation every hour. I have the so this is just like a basic cath lab patient. You're just looking for signs of ischemia in their extremities, you're checking their pulses, all that stuff. But really the important stuff is gonna be here. So we have their operating mode, which will always be auto. Their trigger will always be EKG. Assist ratio was whatever's ordered by your physician. Zero calibration. There is a way you can calibrate this and have it run like some self-test. If you hold calibrate pressure for 2 seconds, it'll go through a whole test process. Then there's where you can chart all your pressures. But keep in mind, you can only chart your unassisted pressures in 1-to-2 or 1-to-3 because they don't exist in 1-to-1 because it's only assisted. But every 2 hours, we're gonna have to switch from 1-to-1 to 1-to-2 just so we can know what's the patient really doing. So, and then also every 2 hours, we're gonna run a strip, and all we have to do is hold down on this bottom right button here, and it'll print a strip in the back. I think I held it down a little too long, but it's super long. But it also, you put this in the chart and it prints out all that stuff for you too. So this is what you'll be charting, is whatever you put into the chart. So then a few little emergency things. So this balloon can only be in standby for a few reasons. If you put it in standby, it should only be for a chest x-ray or to auscultate for the heart and the lungs. Because you'll just hear this if you're trying to listen to them. And then the chest x-ray, you'll just get a bunch of minutes if you try to do it. If for some reason your balloon is in standby for 15 minutes, this machine will start freaking out and alarming you. If it's ever in standby for 30 minutes, the balloon is bad, it has to be taken out because there's a good chance a clot formed on it. And then if you go to turn it back on, you're screwed. So now, if for whatever reason your balloon isn't working, you can't figure out why, you've got a chest x-ray, you've done all this stuff, and you page the doctor and you're waiting on them to come, there's a chance you may have to manually inflate this balloon. So let's just say it's not working, it's in standby. In our kits, it comes with this little stopcock and a syringe. It's or just a 50 ml syringe. You can hook up to the stopcock. It's actually right here. This balloon is run by helium, and the clear tubing's the helium. You disconnect from that. And this is all built into the policy, so this is only like emergency stuff. What you do first is you're gonna pull back on the balloon, and you're gonna be looking for any blood in the tubing. If there's blood in the tubing, it means your balloon ruptured, and that's what the problem is. Because there should only be gas in the balloon, no blood or fluid at all. So there's no blood, so you're good. You're gonna draw back to 40 mils. And every 3 to 5 minutes, all you're gonna do is inflate it and then deflate it. And it's not gonna inflate as much as it does when the machine does it, but I think that's just to keep clots from forming on it. But go ahead and hook it back up. So every 24 hours, we're gonna order a chest x-ray. We're gonna watch their platelet count for bleeding as well. Hourly, we're going to be checking their urine output too, because if this balloon gets dislodged or pulled back, it can occlude the renal arteries, and now you're lost perfusion to your kidneys. So, let's see what else we got here. Oh, you should probably consider immobilizing the extremity wherever it's going in, because if this goes bad, you got a big problem. So, and let's see. There's also in our policy, it's built in to notify the physician for urine output if your augmentation is only 5 greater, or is it 5? Yeah. Oh yeah, if your augmentation is 5 less or 5 above the systolic, then you need to page the doctor as well. So it was 14 and this was like in the 90s. That's good. But if it's only 5 above, it means for some reason it's not working as much as it needs to. To change helium, you can see my helium's halfway full. Even when it drops to red, it's not the end of the world. You need to get it changed, but it's not like a time urgent thing. You have plenty of time to get it changed. Helium tanks are stored in cath lab. And down here on the right, there's a HE helium thing. This pops right off. This drawer slides out, and there's these little tiny helium tanks in cath lab. Then you just hook it up like an oxygen regulator. Some other things, even if your patient's in AFib, if the rhythm's irregular, it'll still work because it's just looking for those R waves. So as long as your patient's having QRS complexes, then it's gonna work. So, I think that is about it, unless you guys have any questions.